but it is a surgical tool which works very well when it is used for the right patient by the right person, which is the surgeon in your case. So let's talk about direct anterior approach, its benefits, its risks, and how this is going to benefit you if you require a hip replacement surgery. So I have kept few questions, few headers, few pointers to make this session more productive. The first thing is, what do I gain if I do a direct anterior hip replacement surgery? First of all, the recovery is faster because no muscles are being cut. We cannot debate that because we are not cutting any muscles during the surgery. So the patient's early recovery in the first 6 weeks to 3 months is definitely faster as compared to conventional approaches. Yes. So we say that this muscle sparing approach is useful because it doesn't cut any muscle, and of course the overall muscle damage is less, so the body has to do less healing. The next thing is, it has lower dislocation rate when it is done correctly. I recently operated a patient whose hip replacement was done by direct anterior approach, and he came with a dislocated hip, and that patient was walking on it for almost 1.5 years because the dislocation happened anteriorly. We have to understand, when we do direct anterior approach, the chances of dislocation are definitely reduced if it is done correctly. But if it is not done correctly, the chances of anterior dislocation, which means the ball can dislocate in the front, are higher. So in this patient, the same problem had happened. The ball had dislocated, it was lying in the pelvis. So we had to do a lot of hard work to take it out and revise that and give a stable hip to that patient. So direct anterior approach is not immune to dislocation. When the surgeons talk about having lesser dislocation rate, they mean that when compared to a conventional approach, if direct anterior approach is done properly, if the hip replacement implant has been placed in the right position, in the right angles, and your hip anatomy has been restored, only and only then direct anterior approach has a lesser dislocation rate. It does not mean that direct anterior approach hip replacement cannot dislocate. I have seen and I have revised direct anterior hip replacements done elsewhere when the patient was in immense mental and physical pain. Okay, so the approach, whether it is a mini posterior, let's say even conventional posterior, if the hip anatomy has been restored, if the ball and the socket has been placed in the right position, in the right angles, then you may recover slowly if it was a conventional approach, but you will get a stable pain-free hip for sure. That's the commonest myth people have. When we surgeons want to add value to our patients' lives, we continue to research, we continue to find new avenues to help our patients. And direct anterior approach is one such tool which is being popularized now because it is a truly muscle sparing approach. But remember, if the hip has been not replaced well, has not been done the way it is needed to be placed in your body, then even direct anterior hip replacement can dislocate. The next thing which I want to tell you, yes, definitely people get earlier confidence in their activities. Right? They get confidence earlier. They know, oh wow, my leg feels, my pain is gone, which is a common thing in every hip replacement. After the surgery, you will feel my AVN pain is gone, my ankylosing pain is gone, my hip movements have been restored. All these are true for every hip replacement. But direct anterior patients are lying so comfortably in bed. When I go and see them on this day of surgery or on the next day, they have smile on their face, they are able to move their hip, and especially the ankylosing patients, when they bend their hip and they realize, oh, the bending has come back. My movement was not there earlier, and now I have the movement back just within few hours. And that's magical for them. That's what brings that broad, bright smile on their face. But direct anterior patients are able to bend easily. They are able to move easily. They are able to take side turns easily. They are able to cooperate with the physical therapist easily. So these are the benefits. These are the benefits of direct anterior approach. All right, so let's talk about, people think, okay, if I undergo direct anterior approach anywhere, then it is guaranteed that I'm going to get a good outcome. It is guaranteed that my hip is not going to dislocate. So that's not true. Direct anterior approach has the steepest learning curve. What do I mean by that? I mean that it takes a lot of surgeries under the belt for a surgeon, which means that if he has done good amount of surgeries, good number of surgeries, only then the learning curve is over and the surgeon is able to reproduce a very good hip replacement surgery for his patient. So if your surgeon is not confident in doing direct anterior, do not argue. Do not say, okay, sir, I want to do direct anterior and I want to get it done by you, because that hospital or that surgeon is near your house. It is convenient for you. And in today's time, the surgeon who has done, let's say, very few surgeries, he may not be able to give you the kind of outcome you are looking for from direct anterior surgery. Let your surgeon do the surgery from the approach he is most comfortable with, he is most experienced with. Believe me, you will get a very good outcome. And if you want it to be done by direct anterior approach, discuss all the pros and cons in details. And I would highly recommend you to go and meet other surgeons, also take opinions. Ask your surgeon how many direct anteriors that surgeon has done, for how many years he has been doing it, and also speak to a few patients who have undergone the surgery through direct anterior approach. In my practice, I have few patients who were operated by mini posterior on one side, and then when I started doing direct anterior, we started doing direct anterior on the opposite side, and the patients in the recovery 3 months later, they can't really make a difference. So it's the same. Only if the hip replacement is performed well, then in the initial phase you may definitely get earlier recovery. Okay, so but there are some risks with direct anterior approach which you all should know before you choose your approach. There is a nerve called lateral cutaneous femoral nerve. Now this nerve is in the front of the thigh. When we do the surgery by anterior approach, then we go from the front. We know it, right? Give me a thumbs up if you know that anterior approach is done from the front with the patient lying supine, which means you're lying on your back. While posterior approach is done from the side and the back with the patient lying on the side. How many of you know that? Give me a thumbs up in the comment section. Give me a thumbs up. Let me see a few thumbs up coming there. I'm not sure if my voice is reaching all of you. If it is, then I'm expecting few thumbs up from you so that I understand that you are able to listen to me, you are able to understand what I'm saying. Yeah? Only Abhinash Dash. Only one person is knows that it is from front. Yeah, is it so? So friends, direct anterior approach is done from the front side. Let me just show you. I'll stand up for you and show you. It is done from the front side, front pocket side. Okay, while the posterior approach is done from the incision is here, not here. Anterior approach is here. Okay, so when we do the direct anterior approach, there is a nerve in the front which is called lateral cutaneous femoral nerve. It is a sensory nerve, which means it just carries sensations. It does not carry it doesn't supply any muscle for power. This nerve can get irritated in a few patients and you may feel burning pain in the front of the thigh. You may have some numbness, vague numbness. You don't feel that area when you touch, especially on the upper and outer aspect of thigh, which usually settles down in majority of the patients in few months, but you should be aware of it, right? The other thing is there is a risk of femoral fracture. You should also know that, because in direct anterior approach, the femur preparation that is the preparation for your stem, that has the steepest learning curve for a surgeon. So sometimes during the preparation of the stem, the femur can fracture and you may end up with a longer incision while you are going in with a mindset that I'm going to get a minimally invasive surgery, and minimally invasive for patients means smaller incision. And for a surgeon, it means minimum muscle damage, faster recovery. Okay? So it doesn't mean that smaller incision is MIS. Some people confuse it with that. Okay? So fracture risk is higher when compared to a mini posterior approach. Wound issues. So wound issues in obese patients, especially who have big abdomen which is hanging onto the thighs, upper thighs, they can have wound healing issues. But obese people can have wound healing issues in any approach. It could be posterior, could be direct anterior, could be anterolateral, it could be the knee replacement also. Wound healing can be delayed in obese patients. We always counsel them. Okay? So direct anterior approach is no exception for that. And I would like to tell you, for you as a patient, hear me out with a lot of attention, because this is very, very powerful and very useful for you. What matters to you is not the approach. What should matter to you is a good outcome, is a good result from the surgery. If your outcome is not good, be it a direct anterior approach or a lateral approach or an anterolateral or a posterolateral, it does not matter. If you're not able to walk pain-free with equal leg length, with a stable hip, without even having a idea in your head after a few months that you have undergone a surgery, then it is of no use. What I mean by that, by 6 months, majority of the patients will forget that they underwent a hip replacement surgery. They start doing their activities and they start living their life so normally that they forget that they underwent a surgery. This is also quantified in medical literature, in orthopedic literature. We call it FJS, which means forgotten joint score. And it is very high after a hip replacement. Okay? So these are the few things which you should bear in mind. I told you the benefits, I told you the risks, and I told you what is the best thing for you. The best thing for you, the only thing which should matter to you is good outcome. And the parameters to get that is to choose an experienced surgeon, choose a good hospital. Do not bother which approach. Bother if you have chosen your surgeon already, then go by the approach he is most comfortable with. You will get a good outcome in his hands. And if you wish to do it by direct anterior approach, then go to a surgeon who does it regularly. And do not worry about the distance. I get patients coming from all across India, from Chennai to Jammu and Kashmir, from northeastern states to Gujarat. And these people believe that they want to get it done by a particular approach, by an experienced surgeon, in a good hospital, which has a good surgical team and good hand-holding support after the surgery has been done. If you want all that, then you should not worry about the distance. People do come from Bangladesh, people do come from Nepal. So think about these people. They also have language issues. Bangladeshi patients have to get their visas and all those things, but yet they choose to come. So that should be your criteria, okay? Okay, let me see what else I had written for you. Let me close this section by telling you every surgical approach has a price. When I say price, it's not only money. It is also the effort you make to reach a particular place, which is traveling. It is also the faith you have and the research you have done to choose your surgeon. It is also the amount of money you have spent in surgical cost and the implant which you have chosen. There's so many things which come into picture. That is the price. If you're ready to pay that, then people will travel, people will save money, people will borrow money, because it is not an expenditure. It is an investment. It is an investment which you make in a healthy, pain-free future. Yes? Give me a thumbs up if you understand what I'm saying. Give me a thumbs up if you agree with me. I'm waiting for few thumbs ups. I have so many familiar names in the chat box. I could see Rajesh Gupta. I could see other patients of mine, and I know so many of them have been operated by mini posterior, and ask them, they're living a fantastic life. And also a few patients who have been operated by direct anterior, and they are also living a very good life. In direct anterior, the initial phase is definitely easy. Yeah. All right. So let me debunk another myth which people have, that DA is the best approach. If I do my surgery by DA, then I have it, I have everything, and I don't need to worry. It is just like a blessing of God. Then let me tell you, direct anterior approach was being practiced for years and years and years in Europe. It just picked up in the US in last 5-7 years, and in India also. So every country goes through a change and a change in the trend of surgeries, and also there are certain training opportunities for the surgeons to go and see the work of other surgeons in different countries and then bring it to India, bring it to their own country like we have done, so that we can offer the best treatment to our patients in our country. Imagine going for a hip replacement surgery to the US. It will cost you a bomb. It will cost you 10 times higher than what it costs you here. People do go to other countries. But when everything is available in the country, then you can choose your surgeon in the country, have the convenience of getting it done in your own country. So let me tell you who is the ideal candidate. I also wanted to bring that up. So ideal candidate would be a person who is not very heavy in weight, which means that, first of all, let me tell you, can we do it for obese patients? Yes, with experience we can. But people whose BMI is less than 40 are good candidates to undergo direct anterior hip replacement. This is one of the criteria. Okay, people who are in like 40 above, they are in grade 3 obesity and they are not the right candidates. They may have challenges. Their chance of having a fracture of the femur is higher. Then second is the hip anatomy. We also see your x-rays. We check your x-rays. We see whether your x-ray is suitable to offer you a hip replacement surgery by direct anterior approach. With experience, we are able to take up most of the cases, but certain cases pose challenge even in the hands of experienced surgeons. And we identify them, we talk to the patients, we counsel them, and when it is a challenging bony anatomy, then the muscle stretching is very high, even in direct anterior approach. Sometimes we have to also release one or two muscles, which primarily we don't need for 90% of the patients. But in these patients, we may have to cut one or two muscles, which are cut through the mini posterior approach also. These are called short external rotators, like piriformis tendon, like conjoint tendon, which we take out in mini posterior approach and repair them later. Okay. Number 3, previous surgeries. Patients who have undergone surgery of the hip in the past, like say fracture fixation, acetabular fracture fixation, neck femur fracture fixation. These are the people who pose challenge for through direct anterior approach. Can it be done? Oh yes. Do we do it? Oh yes. But you should know that if you have an implant inside, especially if there is a damage to the acetabulum which needs reconstruction, then probably if the damage is more on the posterior side, then posterior approach is better for you. But can it be done by direct anterior? Yes. What I'm trying to convey, the ideal patient. And do you know, 80% of the patients qualify for a direct anterior approach while we follow all these criteria. I told you obesity, that is the body type. Second is the hip anatomy, which we study on the pre-operative hip x-rays. Third is the previous surgeries, if you've undergone any previous surgery. Fourth is the muscle stiffness or muscle bulk. If I have to operate a wrestler, or let's say somebody who is a bodybuilder and who has huge muscle mass on the thighs, then such people also pose a challenge for direct anterior hip replacement. Yes, and then lifestyle expectations. Now this poses a challenge in every approach. I have patients who are as young as 21, 22. I've done mini posterior ceramic on ceramic for them, and I've also done direct anterior ceramic on highly crossing poly for them. But these youngsters, they have a very, very active lifestyle. I know a few of them who are running half marathons. I know few of them are doing mountaineering, few of them are doing trekking regularly, and a lot of females who love dancing, they are dancing, they are doing garba, they are doing dandiya, so they are doing bhangra. So we have to see that we offer the best implant and place it in the best position in your body. When you do the best implant in the best position from a surgeon who is experienced, who has a fantastic surgical team, who operates in a dedicated joint replacement operation theater, be it in a smaller hospital. If you're not a high risk patient, all these criteria can be met in a relatively smaller hospital also. And these smaller hospitals are also able to bring the cost down to a reasonable level when compared to a bigger hospital. Then you can get a very, very good outcome. Okay, so you just bear these things in mind when you are choosing your surgeon, your hospital, and where you want to do it. Okay, so let me take you to the next topic which I wanted to with next points which I wanted to cover for all of you. So a lot of people have anxiety, when walking actually feels normal. So this is different for different patients. Some people feel normal within a week. I have seen people walking normally without stick within a week. But these are the guys who have been who give it all, who do everything we tell them, who have been doing some strengthening exercises also before the surgery. These are the people who come to us in the early phase. They are not lingering it on for years and years. And they have that motivation, they have that mental strength. And these are the people who are excited. Do you know what my patients sometimes tell me before the surgery? I ask my patients, are you worried? Are you scared? Are you anxious? A few of them say yes, but a few of them say something very beautiful. They say, sir, no, I'm excited because I'm going to win over this disease tomorrow. When you have operated upon me, I will be an avian warrior. I will be an angst-pond warrior, which means that my disease is behind me and my bright future is ahead of me. I meet them, they're smiling. Believe me, that smile fuels me. That smile gives me the reason to work from 6 o'clock in the morning till 8 o'clock in the night, every single day. To come and that one Sunday which I get, it gives me energy to come and talk to all of you on that Sunday. Yeah, all right. The next reality check is, if you have pain after the surgery, should it worry you? So if you have pain after the surgery, you should expect some stretch pain after the surgery, even by direct anterior approach. Don't think if you have done a surgery by direct anterior approach, then pain is gone and it's like a magic and something has happened, I won't know. So if your expectations are realistic, which we tend to bring them to a realistic level in the pre-operative counseling, then you get a very good post-operative result. All right, so I have a question which has highlighted. All right, so Lamine Yami, I'm going to take your question. It's a good question. I'm going to cover it up. Allow me to finish this off. I have certain important things lined up for all of you. So let me just finish it off. Is it okay, Lamine? Give me a thumbs up if you're okay with it. I'm going to definitely cover your question. I'm writing it down so that sometimes it goes up. All right. So I was talking to you about, I lost the track of things which I was referring to. All right. So we were at reality check. Yeah. If the pain is increasing with movements with every passing day, if you never had that kind of pain which you're experiencing now, let's say in the first 2-3 days you felt the stretch pain, but now suddenly after 2-3 weeks your pain has gone 2-3 times higher, you should be worried. You should definitely get in touch with your surgical team. If your increase in pain is associated with shortening of your operated leg, then there is a very high chance that the hip has dislocated. You should definitely be worried. If your movements are suddenly, what happens when you dislocate? Your pain will increase. Most of the people will hear a sudden pop. Their leg will become short. You will not be able to move your hip freely the way you could. Even moving in the bed will be painful. And in that moment, you know that something is not right. And you should immediately contact your surgical team. Yes? All right. Then, if your pain is associated with discharge in the stitch line, which means a lot of bad colored fluid is coming, which could be soaked in, your dressing may be soaked in blood, and it is repeatedly coming, and your pain is increasing, you are running high grade fever, you are not able to move your hip freely, your appetite is going, you should definitely be worried. Yes, and then you should definitely contact your surgical team. But pain which is there, which is tolerable, which was there yesterday, today I'm feeling better, next day I'm feeling little heavier, then lighter, and this up and down pattern of pain during recovery phase is okay. You shouldn't be worried about it. Yes, definitely, if you have any concerns, then you should go and speak to the one of the team members of the surgical team and get it cleared. So what are the recovery timelines? So let me answer this. After a direct anterior hip replacement surgery, usually patients are doing very well at 2 to 3 weeks, which means that they are able to walk without any support. They are able to walk confidently. What do I mean by that? They're able to bend their hip flex easily. They're able to take side turns. They're able to sit on a chair and do a Zoom call, do a online meeting, do a work for their hospital, work for their office, work for their company or for their business, whatever it is. But what doesn't happen, that people may still have limp. As I told you, limp is dependent upon the muscle weakness which you had before the surgery. If the muscles are very weak before the surgery, then the limp takes time. If you have significant pelvic tilt before the surgery, then limp goes in few months sometimes. If you are a heavy built person with a pelvic tilt, it takes even longer. Yes. So next thing would be, so if you have undergone a hip replacement surgery by direct anterior approach, but you have inflammatory arthritis, which means it could be rheumatoid arthritis, it could be ankylosing spondylitis, it could be SLE, it could be Sjogren's syndrome, anything which is an inflammatory disease which has led to damage to your hip, direct anterior approach hip replacement will only take care of your hip pain, not the other joint pains. That's why we have a rheumatologist in our team, and that rheumatologist takes care of all our inflammatory arthritis patients. They are put on specific medications. Few medications are to be stopped before the surgery. There is a duration which is different for different medications. These are called biologics. These are to be stopped before the surgery, and they are to be initiated again after the surgery, so that we are able to control the disease and your other joints do not get damaged. Yes. So let me close this by telling you that if you are deciding upon hip replacement surgery, then the next step is not only to choose the approach. You have to choose a path, and that path has many components in it. Which surgeon? Am I ready to travel? Am I ready financially to choose the best implant? Do I have a good support system in the family and friends? Am I visiting a center of excellence? What are the results of that center of excellence with the patients who have undergone a direct anterior hip replacement earlier? On the basis of all this, you decide where you want to go, then discuss everything which I have told you in details with your surgeon, have your doubts cleared, and then go for it. And if that happens, then I always say the right patient with the right mindset in the hands of a right surgeon with the right implant put in the right place, you are going to have a magical recovery. Hip replacement has the power to change your pain and make it your power. So the line is, hip replacement has the potential to change your pain into power. I hope today I could give you clarity on the benefits of direct anterior, the risks of direct anterior, and who it is meant for. All right. So that brings me to the end of what I wanted to tell you. And now let me just take the question which I had received from. Let me just go up. We have a lot of questions there in the chat box. Believe me, if I'm not able to take your questions today, then I'll make sure that I answer them through our videos. So if you have not subscribed to my channel, then I will urge all of you, you are still 38 people in the room, I'll urge all of you to go and subscribe and see a lot of videos there. If you require knowledge about hip replacement, if you are there and still deciding what is to be done, then a lot of videos are going to help you in making that decision. Yes, and that will be very useful. And you can, if you're 38 and I have only 18 thumbs ups, if you give more thumbs up, then this video will be shown to more people who are like you, who need guidance. And if you found value in this video, then please go ahead and do that so that it is recommended to a lot of people. So Lamine, I am going to take your question. The question is, what's your opinion on super path compared to a DAA? So friends who don't know what is a super path is another approach which is talked about more so in the US for doing a hip replacement surgery. This approach, when compared to direct anterior approach, has not shown any advantage in the outcome of the patients, which is the most important criteria to choose whether it is better or not. Eventually, why we are inventing new approaches, why we are talking about new approaches? Because we want to give a good outcome. We want to give a quicker recovery. We want to give an earlier recovery. We want to give a good long-term outcome. So superpath has not shown any benefits over direct anterior approach. Superpath has certain challenges with it. It requires special instruments. It's a surgery which is partly done from the superior side of the hip joint and partly with a stab incision and a special kind of acetabular reamer from below. Definitely, if you ask me, is it muscle sparing? It is. But I would say that this approach is not very popular because this is a tough way of achieving what we can already achieve by direct anterior approach without cutting any muscle. That's my take on it. We may have different opinions on it because you asked me, so I'm telling you what's my take on it. Yes? Lamine, could I answer your question? Give me a thumbs up if I could answer your question. All right, let me just go to a few questions now, and we are already at 33 minutes, and so I'll try to take 10 questions. And first, let me cover one of the questions which came to me on Instagram by Mr. Rohit Mundra, and he said, does spine balance get affected after a hip replacement surgery? So Rohit, here is your answer. If your pelvis has a tilt before the surgery, then usually once the hip replacement is done, the pelvic tilt gets corrected in due course of time. When the pelvic tilt gets corrected, it affects the orientation of your spine also. So sometimes patients do feel pain in the initial phase. I'm talking about those patients whose spine is flexible. Then spine gets corrected along when the pelvic tilt gets corrected, but initially you may feel some pain. Sometimes when the leg length is not equal after the surgery, then the spine orientation can change. Because one leg is longer, other is shorter, the spine gets tilted, and then spine starts to pain. Patients start feeling some pain, some discomfort, which gets better with rest, but when they start walking, it increases. So that's another thing. But if an ankylosing patient who has a bamboo spine undergoes a hip replacement surgery where the spine is fused, sacroiliac joint is fused, the spine balance cannot change. It will remain the way it is. Only the hip pain will go. Okay, Rohit? Could I answer your question? Give me a thumbs up if you're there in the room and if I could answer your question. Yes? There was another question. Let me just see. That question was, which I wanted to cover. So the question is by Wishful Tarots. It says Taros, sorry. It says, sir, can tilted hip and lengthening be corrected after hip replacement surgery? So yes, if your hip has tilt or deformity, then hip replacement surgery can surely correct it. But it depends on patient to patient. I did not understand exactly what you mean by tilted hip, but leg length can definitely be corrected in majority of the patients. If you come and see me, then I can check you clinically and I can guide you better. Yes. So friends, now I'm going to take live questions. I've seen few people have left. So people who are still in the room, I'm going to take few questions which are relevant to direct anterior approach, and then we will close this session. If you have given your question already, then I may cover your question if it is well suited for today's session. Mr. Antor Khan, I fractured my neck of femur 2 years ago. I have no pain yet, and do I have the chance that I may have AVN? Yes, you have, but not every neck femur fracture patient who has undergone a surgery requires a hip replacement surgery or goes into AVN. Even if the AVN happens, then usually neck femur patients are able to pull on for many years, unlike a patient who has got AVN because of steroids or because of idiopathic reasons. Mr. Rajesh Kumar Gupta says, good morning. So good morning, Rajesh. And so Mr. Ashok Prahlad says, can I do stationary cycling, and what kind of a cycle should I use if I'm an AVN patient? Then you can use a bike which is a stationary bike, which is there in most of the gyms. You can sit upright and do it, or if you want to go recumbent, you can do that also. But I would not recommend going bike riding on the roads, because we have all kinds of potholes and traffic, and it is challenging, and sometimes you have to balance, stop, other things, so that's something you should avoid. Yes, Ashok, avian patients can donate blood, not a problem. Lone Babu is asking, Lone Babu, how long does it take for THR to restore muscle strength, and when can the patient walk without a cane? So Lone Babu, this is different for different patients. I covered it during my session today. If you have AVN, then if you have been lingering it on and the hip replacement is done after a long time, then your recovery takes longer time, your muscles are weaker, they take long time to recover. So sometimes these people require 3 to 4 months to gain muscle strength to correct pelvic tilt, and sometimes cane is given for some 4 weeks also. But majority of the patients, when I say majority, I mean 95% and above, do not require a cane if your bone quality is good, I mean beyond 2 weeks. So initially few patients are on a walker, and then my physio team will start giving them a cane, and once they are comfortable, then some wall support, and then everything is out, usually 2 to 3 weeks. Yes. If you are getting answers to your question, and if you are liking my answer to anybody else's question, give me a thumbs up in the comment section. That will really, really motivate me. That will really give me a good feedback on today's program. Yeah, thank you. I'm going to omit few questions which are not relevant to today's topic, so that everybody who has joined for direct anterior approach hip replacement doesn't feel lost. Aryan, come and see me once. So my team numbers are on my channel. Yet if you wanted, I'm announcing it: 987382460. This is a WhatsApp contact number which is working on all the working days between 10 a.m. to 7 p.m. So I told you I'm going to take 10 questions. I have taken 3 already, and then next question is, Ryder Ram given me a feedback that your voice and video quality both are excellent. Thank you, Ryder. Sometimes we are not sure whether you're able to see me or hear me clearly. Thank you for that. So Amit Kumar Sharma says, sir, I had hip replacement surgery on 25th December, but I'm becoming flexible in walking. Very nice. Congratulations to you. I'm so happy to hear that. Good job. So Imtiaz says, I had my surgery 9 months ago, but I still limp. I still have little pain in walking in winters. My legs have started to stutter like they did before the operation. Does that mean that implant is moving? No, it doesn't mean that, but it needs to be checked. You should go and meet your surgeon. Most likely you would require some exercises to build your muscle strength, some training of walking, which is called gait training, and which a physical therapy department can take care very easily, but you should get checked by your surgeon before you go ahead with it. Okay, best wishes to you. Anuj Rajput, I have had a hip replacement for 3 years and now I have pain on the other side too. What should I do? Investigate. Go and meet your surgeon, get your x-rays done. Let's see if the other side is also involved and what treatment should be done for that. Okay? Can I play badminton after hip replacement? I think playing doubles badminton where you're not going crazy about, picking up every drop which is coming your way, then it can be played. I have patients who play doubles lawn tennis. I have patients who do swimming. I have patients who play table tennis and recreational badminton with their family members, like in the society, not really at a crazy level. But yeah, you can be very careful about it and still do it. Please ask your surgeon also before doing it. Amit Kumar Sharma says, I have pain in my toes after hip replacement surgery. Well, that needs to be checked. Generally, it is not related to the surgery. Maybe you have other medical conditions which can be the reason of it, and we can treat that after seeing you. Yes, all the best. I got a lot of thumbs ups when I asked for it. Thank you very much. And Mr. Kanik Pandit. So he says, can I sit cross-legged after bilateral THR after 6 months with MIS technique posterior? Please reply. Kanik, you will have to ask your surgeon, but can the patients do it? Oh yes, they can do it. All my patients do it who have undergone hip replacement for AVN by MIS posterior approach. Yes, they can do it. Majority can do it. We don't force it, but majority can do it. Yes, and people who are still there in the room, if your friends on a WhatsApp group of AVN or ankylosing spondylitis, you think if they're going to benefit by it, then share the link of this program with them so that they can see it later. Kanik has asked this question multiple times. Yeah, Kanik, I've taken your question. And Mario Brothers, why patients have pain after hip replacement frequently? That's not the reality, Mario. Majority of the patients do not have pain after the hip replacement surgery. But can you have it? Yes, possible. And if you have it, then you should go and meet your surgeon. That's the way to go. Allow me to have something. Bhook lag rahi hai. Okay, Ashutosh Panigrahi. Hello sir, ceramic versus oxynium head, which is better? Doc saying oxynium is superior to ceramic, which recently introduced. No, that's not true. I would say oxynium is better than metal. Oxynium is what? Oxynium is a coating on a cobalt chrome head. While ceramic is fully made up of ceramic, it's not a coating. And ceramic is a very, very strong material, especially the 4th generation ceramic which we are using for our patients, Biolox Delta, is very strong. This ceramic is so strong that it is used in the brakes of Formula 1 cars. But what we are using are bioceramics, which means these ceramics are made for human body. In terms of wear and tear, in terms of quality, if you're choosing a good brand of hip replacement implant, then in my hands or in anybody's hands, ceramic will beat oxynium, because oxynium is just a coating and it is very, very scratch sensitive, which means when your hip is being reduced, if the ball scratches on the cup, which can happen sometimes in the real world, then nothing happens to ceramic, but that coating of oxynium can come out and then metal is exposed. So I would use oxynium only in very special cases. My go-to femoral head is ceramic. in all my patients, revisions, primary, everywhere. But yeah, oxygen is good, not bad. Naseeb SK, can I, after hip replacement, can I sit properly in a chair? Oh yes, why not? You can. So I had a surgery done which I got infected, but I put a spacer. The hip that also got damaged. Now it's empty and I'm taking antibiotics. The infection will go away, right, sir? Piyush, very sad to hear this because infection is the worst complication which can happen after hip replacement surgery, and the chances are less than 1%, and to be in that less than 1% people is like very unfortunate. I wish you all the best. Yes, the infection can be cured and people do go back to their normal lives, but it is a long path, my friend. It's going to take a lot of time curing the infection first, then reconstructing your hip, and then the recovery of the hip replacement. My best wishes to you, and I hope you will get better very soon. Sakshi Singh, what is your question? You're saying please reply to my question. Where is it? It must not be something which is directly related to our today's topic, then I must have skipped it. Please reply. Sakshi is again saying please reply. Let me see. I want to ask that it is happen to hold on 4 month rest after bed after surgery. What is that question? I want to ask that it is happen to hold on 4 month rest on bed after surgery. I think you're trying to ask, is it possible or is it required to have 4 month bed rest after a hip replacement surgery? No. After a hip replacement surgery, mostly patients are up and about very early. Let's say if there was a complication or if there was a special situation in your case, then yes, extended amount of weight bearing restriction is there, which could go up to 6 weeks, sometimes 8 weeks, sometimes 10 weeks, sometimes 12 weeks. But bed rest, no. Patients are moving around with walker, no bed rest. Very rarely do we, I don't remember in fact, when I told my patient that you have to take bed rest for 4 months. No, I can't recall. But your case may be special. Kindly consult your surgeon and take it forward from there. Yes, and friends, how much time? How much time? Okay. Sakshi, I've answered your question, right? Dashrath Mandal, sir, please, I am from Assam, L4 L4 spine. We're not discussing spine issues today. I'm a hip and knee doctor, so please consult a spine doctor. Puneet Surya. Puneet, what is your opinion on MRP knee? How do I answer this? I have no opinion on MRP knee because there is nothing like it in the scientific literature. The knee surgeries are partial knee replacement, total knee replacement, high tibial osteotomy, knee arthroscopy. When we talk about partial knee replacement, it is two types. I have a full video on it. Go and check this video on my YouTube channel or Instagram, wherever you follow me. It's different types of partial knee replacement implants. You can find it in last 1 month videos. If you go to short videos and you start scrolling within last 1 month, I think 1.5 month, you will find I'm holding two models and showing it. One partial knee replacement is mobile bearing and other partial knee replacement is fixed bearing. That is all. And the plastic which goes inside the mobile bearing partial knee replacement is is called meniscal bearing. So we have a part on the femur, small, we have a part on the tibia, small, and small size, I mean, and in between we have a plastic like any other joint replacement, which is moving in the joint, and it is called meniscal bearing. But what you mean by MRP, I have no opinion on MRP. MRP is nothing. I have more than 20 years of experience in doing hip and knee surgeries only, and I'm yet to read this anywhere in the scientific literature. I don't know from where it is coming, and a lot of people are asking me these days, MRP, MRP. I don't know what it is. Looking for another good question. How about you? I have a plate fitted after femur head dislocation, I presume. It was done 70 days ago. I have a foot drop. What is the recovery time? Well, foot drop can take a longer time to recover, my brother, and it may not recover sometimes at all if the injury was bad. Hip dislocation can damage sciatic nerve, which is on the back side of the hip. And if the damage was severe, then sometimes it doesn't recover, but the recovery can take as long as 8 months to 1 year. So keep doing your physiotherapy, keep meeting your surgeon. I'm sure he will guide you if it doesn't recover. Varahala Babu Petta. Sorry for the wrong pronunciation. I'm not able to. Babu Petla. Is Max company implants are good? Yeah, they're good. They have different categories of implants. They're good. All right, friends, and that brings me, I think, to the end of the program. And I receive everybody's good wishes. And thank you so much for logging in today. I'm taking. Yeah, in special case, Sakshi, it can be there. I'm sorry if I have not seen the case, then I can't really say it. But yeah, it's very uncommon to give 4 months bed rest. If there is a special situation, surely it can happen. And Abhinash Dash, I have ankylosing spondylitis. My hip joint gap is no more. 13 and 14 disc bulged. L3 and L4. Oh, I see. My leg rotation is restricted. How much time can I take to sit cross-legged in Indian toilet? Can I tie shoelace? I need to see you. Abhinash. Note down the number of my team I just announced, 987382460, and speak to her on a working day and fix up an appointment. Come and see me. I can definitely help you. We see a lot of angst patients coming from Assam and northeastern area, and they come with fused hips with no movements, and they definitely get better. I have a few videos also on ankylosing spondylitis. You can go and have a look. Aisha Kasim, I have stage 4 AVN with no limp, but I have severe pain in my back and hip, and I'm getting married after the hip replacement. If I getting married after the hip replacement or before 21 years old female? No, I think you should go meet your surgeon and consider hip replacement surgery if you're in severe pain, recover from it, and then get married. Yeah, a well performed hip replacement surgery is going to give you a very good life even after marriage, so don't worry about it. Lemeen Yami, how long it takes DA surgery to complete typically? 60 to 70 minutes. Do you have any anxiety management medicine before the surgery? You are talking about the surgeon or the patient? We definitely give medicines to the patient, and surgeons usually do not require anxiety management. All right, guys. So let me close today's program with this. Thank you so much. It was a very high energy room. I got a lot of questions and I got 25 thumbs ups. And if you like the program, then you can give it a thumbs up. It takes just a click, and that tells YouTube that this is a good program, this helped people, and this is shown to other people who are suffering from similar issues. Thank you so much for watching, and subscribe to my channel to watch more such videos on hip and knee replacement, which are scientific, which are useful, which are simple, and which are useful. Thank you so much for watching. Bye now. Have a nice Sunday.